That's better, Indrani.
Hi, everyone else.
Hi, Indrani.
Shall I open the webinar room?
Radhakrishnan, sir,
Yes.
smile.
Yes.
Good evening, sir. Good evening.
Radhakrishnan, sir, why don't you smile?
Sir, your mic is not on.
That's why. I think.
I'm admitting all attendees.
Right.
Okay.
Hello. Could I be heard?
Good
I
evening.
be heard?
Yes, sir.
Yes, you can be heard.
Good. That's wonderful. So, good evening, everybody. How everybody is keeping?
All well. How are you?
Good. Well, I'm okay. Carrying on.
Great.
So we'll go to the timer, countdown timer.
Yes.
Countdown timer. Okay. Well, yeah. Okay. Let this be projector after some time. Yeah. Okay. Right.
ಏನು ಇದು ಸುಧನ್ವ? ಇದನ್ನ ಹೆಂಗ್ ಮೇಕ್ ದೊಡ್ಡದು ಮಾಡೋದು? How to make it large? Mr. Dr. Sanish, I think I have to join again.
You can. No problem.
Yeah. No, I got it. Yeah.
Good evening, everybody. Welcome to the webinar of Indian College of Anesthesiologists. This evening, we are signing into a new territory, thoracic and vascular anesthesia, which will be dealt in 4 parts. And today will be the part 1 of the 4 parts. And our team from Maharashtra will be enlightening you with the thoracic anesthesia, the specialties with the thoracic anesthesia and the vascular anesthesia. And today, the chairpersons are Dr. Kumra and Dr. Manju Sarkar. Dr. Kumra, since not able to join, I may be stepping in his place for some time. And I am sure Dr. Jayashree Sood is here, and she will take out from me, and we will go to the very end, and we will sign off the particular program from all of us. Thoracic anesthesia, as you know, well, it involves mostly complex surgical procedure. Probably the comorbidities associated and the increase in tendency to go for all complications makes thoracic anesthesia most important. And today, the chairperson is Dr. Manju Sarkar. She may be likely to say something as an introduction on thoracic anesthesia. And after that, well, we will introduce the speakers of the day and we will go ahead. Dr. Manju Sarkar.
I'd just like to give a little introduction for Manjula Sarkar, Dr. Radhakrishnan.
Yeah, please.
Yes. As Dr. Radhakrishnan said, we have two very true eminent anesthesiologists of the country. They are the moderators today. Dr. Radhakrishnan, we all know, is a very dynamic person, and he is the president of the Indian College of Anesthesiologists. In fact, he is the founder member. They are the ones who initiated and had this Indian College of Anesthesiology started, and now he is the president and is very dynamic. Another dynamic moderator that we have is Dr. Manjula Sarkar. She is heading the cardiac anesthesia at the DY Medical College, Navi Mumbai. She was also the head previously in the GS Medical College. She's a very good friend of ours and very senior member of the Indian College of Anesthesiologists and a very active member. So, Ma'am Manjula, could you please introduce the speakers and start the webinar?
Thank you very much, Madam Sood and Dr. Radhakrishnan. I'm really thankful to Dr. Radhakrishnan to accept that he will be with me in place of Dr. Kumra. That was the last minute request and he has accepted it. So thank you very much, sir, for that. And now we start the thoracic anesthesia first webinar. As an anesthesiologist, all of us knows that challenges of thoracic anesthesia is a really difficult task for all of us. The problems which we are going to face in thoracic anesthesia, number 1, the lateral position, number 2, open thorax, number 3, manipulations of the thoracic organs, number 4, major bleeding, and number 5, one lung ventilation and isolation, for which we really need expertization. Diseased lung. So by keeping all these factors in our mind and challenges, I invite Dr. Indrani Hemant Kumar. She's going to tell us about the assessment, optimization and preoperative preparation of these patients. If they are well planned and well optimized, then I'm sure that there will not be that much of the problem during the surgery. So Dr. Indrani Hemant Kumar, the mic is to you now.
Thank you, Dr. Manju, for this introduction. It's my proud privilege to be part of this webinar under the august banner of Indian College of Anesthesiologists. And thank you, Dr. Radhakrishnan, Dr. Sanish, and Dr. Manju Sarkar for this opportunity. Well, I would be speaking on preoperative evaluation and optimization of a patient presenting for thoracic surgery. Why should there be a preoperative evaluation and optimization? Because the postoperative pulmonary contributions following a thoracic surgery is pretty significant. So that can cause a tremendous amount of morbidity and mortality. It increases the length of stay and it increases the healthcare cost. So what happens with anesthesia and surgery, thoracic anesthesia and surgery? Well, no sooner we start with general anesthesia, it can cause impaired lung volumes. There will be a fall in tidal volume, increase in respiratory rate. There will be a loss of sigh. There will be a 50 to 60% reduction in vital capacity and a 30% reduction in FRC. And this lasts for almost a week following the anesthesia. There will be diaphragmatic dysfunction. There will be basal lung atelectasis, VQ mismatching. The reflexes are all decreased, the vagal reflex and the splinting of the diaphragm. All of them will add to the diaphragmatic dysfunction. There will be impaired gas exchange, respiratory depression, which could be because of the effects of opioids, and impaired cough reflex and mucociliary function. The defense mechanism is impaired following general anesthesia. So the complications which can happen following a thoracic surgery is like atelectasis, pneumonia, bronchospasm, exacerbation of underlying chronic lung disease, respiratory failure, and prolonged invasive or non-invasive ventilation. And of course, the surgical complications are also many. It can lead to bleeding, infection, fistula, bronchopleural fistula, etc. So if you see this slide, you will find that following thoracotomy and lung resection, the incidence of pulmonary complication is almost about 30%. So let us first look into the perioperative pulmonary physiology. Following thoracic and upper abdominal surgeries, you will find, as I said, the vital capacity falls to around 70% and FRC is reduced to about 30%. The diaphragmatic dysfunction could happen in the postoperative period, leads to splinting, fall in FRC, atelectasis, pneumonia, and VQ mismatching because of that. And microatelectasis leads to perfusion ventilation mismatch and impaired gas exchange, and a consequence, we get hypoxemia. And to top it all, there is a residual effect of anesthesia, where there will be depression of the respiratory drive, there is inhibition of cough and impairment of mucociliary clearance of respiratory secretions. There will be a decreased tidal volume and increase in respiratory rate. The alterations in the VQ mismatch and the alterations in the respiratory mechanics leads to postoperative pulmonary complications. So how are we going to go about evaluating the patient and optimizing the patient? One is to identify the patient risk factors, procedural risk factors, have a preoperative risk assessment based on these two, and go in for a risk reduction strategy, that is optimization. So what are the patient-related factors? Age, chronic lung disease, asthma, smoking, obesity, OSA, pulmonary hypertension, heart failure, general health status in the form of frailty, etc., or metabolic factors, and surgical factors as in what is the surgical site, what is the duration of surgery, what is the type of anesthesia, what is the type of neuromuscular blockade. All of them should be assessed in the risk factors. Let us move on one by one. Age. When it comes to age, it is a minor risk factor. It's an independent predictor of morbidity and mortality. And any age more than 50 years is an important independent predictor of risk. Presence of chronic lung disease, the respiratory complication odds ratio goes up to 2.36. And remember, there is no prohibitive level of pulmonary function below which surgery is absolutely contraindicated. The benefit of surgery must be weighed against the known risk. What about patients with asthma? A well-controlled patient with peak flow of more than 80% of predicted or personal best will proceed to surgery at an average risk. Smoking, there is increased risk even among those without chronic lung disease. So the relative risk of smoking in a patient is 1.4 to 4.3, and the risk declines only after 8 weeks of preoperative cessation. Obesity should not affect the patient selection for an otherwise high-risk procedure. What happens with obesity? Obesity, there is stiffening of the total respiratory system. There are reduced lung volumes and chest compliance. There is reduced tidal volume, and the breathing pattern is short, rapid breathing pattern. There is reduced vital capacity. There is increased risk of airway closure and ventilation distribution abnormalities. Look at this slide over here. A normal patient with a normal bony enclosure, the airway size is pretty big and it is open. Whereas in an obese patient, you will find that the airway size is so small. So that you can see the anatomical imbalance in the presence of obesity, and presence of OSA will add to the complication. So you will have, these obese patients not only have reduced lung volumes, they have reduced airway diameter and altered airway smooth muscle structure and function. So OSA increases the risk of critical respiratory events immediately after surgery, including early hypoxemia and unplanned re-intubations. Patients with a 4% oxygen desaturation index of more than 5 were more likely to have post-operative respiratory complications. What about pulmonary hypertension? An increase in pulmonary complication rates after surgery, regardless of the underlying etiology, if there is pulmonary hypertension, and if there is history of pulmonary embolus, there's a very high level of mortality. Heart failure, the risk of presence of heart failure is much higher than the risk of presence of COPD. And what about the general health status? The functional dependence and impaired sensorium each increases the risk. Patients with significant pre-existing lung disease would be classified at a higher ASA risk. That is, an ASA class of more than 2 confers a 4.87-fold increase in the risk. And the inability to exercise predicts 79% of pulmonary complications in these patients. So what about the procedure-related risks? Surgical site. The single most important factor in predicting the overall risk of post-operative pulmonary complications is the surgical site, especially in thoracic surgery. So the patients who have thoracic or upper abdominal surgeries have up to 40% increase in the level of complications. So what about patients who go for VATS, video-assisted thoracic surgery? They have reduced pain, lower post-operative complications, reduced release and responses of pro-inflammatory cytokines, and better ventilatory function. So we find that patients who undergo VATS have better outcomes than open thoracotomy. What about the type of anesthesia? General anesthesia leads to a higher risk than epidural or spinal anesthesia, and regional nerve block is associated with lower risk and should be considered whenever possible for high-risk patients. And neuromuscular blockade. Long-acting neuromuscular blockers can have post-operative residual effects, leading to higher incidence of post-operative pulmonary complications. Coming to duration of surgery, we find that if the duration is longer, the complications are much higher. So any surgical procedure which lasts more than 3 to 4 hours are associated with higher risk. A less ambitious, briefer procedure should be considered in a very high-risk patient. And if the patient for thoracic surgery comes to you in the OPD, what will you look for? Look for the gait. Look at the BMI. Look for the phenotype of a COPD patient. You ask and assess allergies, asthma, sleep, snoring, smoking, breathlessness, past treatment, and other comorbidities. You have to order these tests: ABG, chest X-ray, functional evaluation in the form of spirometry, diffusion capacity, and exercise tests. In the history, you need to ask for exercise intolerance, chronic cough, unexplained dyspnea. The physical examination may identify findings suggestive of unrecognized pulmonary disease or a cardiac disease. Look for decreased breath sounds, dullness to percussion, wheezes, rhonchi, prolonged expiratory phase, presence of tachycardia, presence of any missed beats, or any arrhythmia. That has to be found out. One can do a bedside pulmonary function test, and bedside pulmonary function test can evaluate the ventilatory functions of the lung and the chest wall. The best is to do a simple Sabarasis breath holding test, and which gives you the cardiopulmonary reserve. So anything more than 25 seconds is a normal cardiopulmonary reserve. If you have a peak expiratory flow meter, that's a very simple and cheap test to understand what is the PEFR of the patient. So it is mainly used to diagnose bronchial asthma and to monitor exacerbations and response to treatment. So you can measure the peak flow rates, can be done on walking, or it can be done before going to bed. Look at the diurnal variations, if there is any response to treatment. All this can be done with a simple peak expiratory flow meter. Also, a bedside pulse oximeter has to have, pulse oximetry has to be done. And again, coming to spirometry. Spirometry is mandatory for all thoracic surgeries. So it's a measure of static and dynamic functions of the lungs. But remember, PFT should not be used as the primary factor to deny surgery on these patients. These tests simply confirm the clinical impression of disease severity in most cases, adding little to the clinical estimation of risk. Please understand what I said. I said that PFT has to be done. It estimates the disease severity, but it does little to estimate the risk, postoperative risks in these patients. So a spirometry can measure everything, but it can't measure FRC, residual volume, and total lung capacity. And also there is a considerable debate regarding the role of preoperative pulmonary function testing for risk stratification. However, we have to do the preoperative test. So a forced vital capacity or a FEV1 or the ratio of FEV1 by FVC. If it is less than 70%, we are looking at a very high complication risk. However, please remember, a normal PFT does not demonstrate a lower postoperative complication risk. ABGs have to be done. PaO2 less than 50 millimeter mercury or a PaO2 less than 60 millimeter mercury with a PaCO2 more than 50 millimeter mercury will increase the risk of complications in these patients. PaCO2 more than 45 millimeter mercury in a lung resection is associated with high risk. Hypercarbia in patients with COPD is not a clear contraindication because you are expecting hypercarbia in these patients. It is not a clear contraindication, mind you, but it is believed to be a high surgical risk. However, if the patient has hypoxemia, it is not a significant predictor of complication alone, remember that. So only hypoxemia does not say that the patient is going to have a complication. So current data do not support the use of preoperative ABG analysis to stratify the risk for postoperative pulmonary complications in general surgical patients, not thoracic surgery. So preoperative exercise testing has to be done. So that is either a walking test or a stair climbing test or a shuttle walk test or a bicycle ergometry where we can find out the MVO2. All these are done. These are done for lung resections, but not routinely done for general surgery or a general thoracic surgery. A chest radiograph is mandatory for all thoracic surgical patients. The available literature does not allow an evidence-based determination of which patient will benefit from a preoperative X-ray chest in other patients who are not undergoing a thoracotomy. So preoperative X-ray chest is essential if it is more than, the patient is more than 60 years with cardiac or a pulmonary problem. So having done the preoperative tests, now let us look into the risk indices. You have to, based on what you have tested and all the history and investigation, you need to have an assessment of the risk. So the pulmonary risk index is, it is a combined CPRA, that is cardiopulmonary respiratory index, which is based on both Goldman criteria, which we already know, I'm not going to go into it, which assesses the cardiac risk, and the pulmonary risk index, which I'm going to say now. So what are the criteria which you are looking at in the pulmonary risk? One is BMI more than 27 kilogram per meter square, cigarette smoking in the last 8 weeks, productive coughing, wheezing, FEV1 by FVC less than 70% of predicted, and a PaCO2 of more than 45 millimeter mercury. If you have given 1 point each, you have to understand any patient with more than 4 will have a 73.4% risk of complication, and a person less than 4 will have about 11% risk of complication. Then there is another risk index called the multifactorial risk index. It takes into consideration the type of surgery. So whether it's the thoracic surgery, it gives an index, it gives you a value of 21. If it is an emergency thoracic surgery, again add 11. If the albumin is less than 3, add 9. BUN more than 30 grams per deciliter, add 8. And functional addiction in the form of smoking, you can add 7. COPD 6, age more than 76, and age more than 60 to 69, add about 4. So if you add up the score, higher the respiratory insufficiency in the post-operative period. So you will find anything, if the score is more than 40, there is a almost 30% increase in the respiratory insufficiency. This is again a very important risk index, that is ARISCAT score, which takes into consideration 7 independent risk factors, which has a regression modeling. So what are the 7 risk factors? One is age, then preoperative saturation, respiratory infection in the last month, preoperative anemia, surgical incision. Where is the surgical incision? Is it periphery, upper abdominal, intrathoracic, duration of surgery, and emergency procedure. So what they give you a risk score of each. So if it is 51 to 80, it is 3, age more than 80, it is 16, so on. So they give you a risk score based on these 7 indices. And if the patient is low risk, if the patient has less than 26 points, so the PPC rate is 1.6%. Intermediate risk is if the patient is less than 44 points, where the PPC rate is 13.3%. And high risk if the patient is having more than 45 points, that is a rate of 42.1%. So what about patients who are undergoing a pneumonectomy or a lobectomy, etc., or a wedge resection? So the aim in the preoperative period is to identify the severity of existing pathology and its reversibility, estimation of predicted pulmonary function after resection. So you need to do a general evaluation, which I already told you, have to do a 3-legged stool assessment. So which gives you a pre-thoracotomy respiratory assessment in the form of spirometry, diffusion capacity, post-operative, predictive post-operative FEV1, FVC, DLCO, VO2 max, etc., ABG, and exercise capacity. So what we have to do in these patients? You do a preoperative lung function. If the FEV1 is more than 2 liters, or it is 60% more than 60% of the predicted, and if the DLCO is more than 60% of predicted, go ahead and do the lung resection. However, if the FEV1 is less than 2 liters or less than 60% of predicted, and if the DLCO is less than 60% predicted, you need to go to the next step, That is, you have to do the split lung function studies. So what do you do in the split lung function studies? You have to find out the predictive post-operative FEV1 and the predicted post-operative DLCO. If both are more than 40%, go ahead and do the thoracic surgery, the pneumonectomy. However, if it is less than 40%, you have to get into the third step, which is the cardiopulmonary exercise testing, where you find out the VO2 max. VO2 max is the aerobic capacity of the individual, wherein if it is more than 15 ml per kilogram per minute, or if it is more than 50 to 60% of the predicted value, then you can go ahead with the thoracotomy. However, if it is less than 15 ml per kilogram per minute, you need to go to a less morbid procedure, like you need to go for a lobectomy or a wedge resection or a VATS, whichever is appropriate for the patient. So you need to do an FEV1, which is the primary parameter. So in the pneumonectomy, preoperative FEV1, I told you, should be more than 2 liters. Lobectomy, it should be more than at least 1 liter. And wedge and segmental resection, it should be at least more than 600 ml. So the predictive post-operative FEV1 is also used to find out if the patient is, whether we can extubate the patient. So if it is more than 40%, awake, alert, and warm, comfortable patient can be extubated. What about DLCO? As I said, DLCO, if it is less than 50% of predicted, major resection is contraindicated. If it is less than 60%, mortality risk is 24%. And if it is less than 40%, mortality risk is about 33%. So we go into the next, that is the split lung function studies. So split lung function, it predicts predicting the post-resectomy pulmonary function. So these include FEV1, FVC, MVV, and residual volume by total lung ratio, TLC ratio. The test should be expressed as a percent of predicted volume corrected for age, sex, and height. So here we try to find out the predictive post-operative FEV1, and we want to find out the post-operative TLCO. So post-operative FEV1 is the most valid single test available. And how do you find out the post-operative predictive FEV1? That is preoperative FEV1 into 1 minus the functional lung tissue removed percentage divided by 100. So what do you mean by the functional lung tissue? What we mean by that is the lung function can be calculated by counting the number of segments involved. The lung contains 19 segments, 3 right upper lobe, 2 right middle, and then we have the 5 right lower lobe, 3 left upper lobe, 4 left lower lobe, and 2 left lingular. So based on that, you can count the number of segments which have to be resected and then use that in the formula. So the other split lung function studies which can be done to assess the patient is doing a VQ scan, that is a ventilation perfusion scan, or a quantitative CT. So once you know that the FEV1 and the DLCO post-predictive function by the VQ ventilation perfusion scan or the quantitative CT is less than 40% of predicted, then you go into the next step, which is cardiopulmonary exercise testing. So this is a very important to know in lung resection surgery. So it is the amount of oxygen requirement for major muscle groups for 5 to 15 minutes at least. And it can be estimated by doing a 6-minute walk test. So ask the patient to walk briskly, a 6-minute walk. This we are doing even for COVID patients. Distance in meters divided by 30. That is 6-minute walk test, that is 450 meters. Estimated VO2 max will be 450 by 30, which is 15 ml per kilogram per minute. So if it is more than 15 ml per kilogram, a patient is operable. Less than 15 ml per kilogram, it will be patient is high risk. So you know that the stair climbing is a test used to calculate VO2 max. That also can be used. The ability to climb 5 flights correlates with a VO2 max of more than 20 ml per kilogram per minute, and climbing 2 flights of stairs correlates to a VO2 max of about 12 ml per kilogram per minute, which is a very high risk. and a patient with a decrease of SpO2 of more than 4% during stair climbing also have increased risk of morbidity and mortality. So if you have VO2 max of more than 75%, good prognosis. If it is more than 60%, more than one lobe is contraindicated. If it is more than less than 43%, any type of resection is contraindicated. So the cardiovascular recommendations before lung resection, that also has to be done. That is, cardiac risk should be stratified, preoperative ECG, echo, etc. should be done. And if the patient had a myocardial infarction, at least wait for 6 weeks and take a cardiac opinion. And the major risk for perioperative cardiac morbidity are unstable coronary syndromes, angina, decompensated heart failure, arrhythmia, AV block, symptomatic ventricular arrhythmia, SVTs, uncontrolled ventricular rate, severe valvular disease. So having done the preoperative evaluation, you need to optimize the patient. So that can be done by the 5-prong attack. So what are they? Stop smoking, dilate the airways, treatment of infection, treat anemia, electrolyte imbalance, loosen and remove the secretions, and measures to increase motivation and education and to facilitate the post-operative care. Treat the chest infection with the appropriate antibiotics, give proper bronchodilators, you can give steroids. Remember, all this can have a good reversibility on the lung function and have a better outcome in these patients. Thank you very much for this opportunity. And a good preoperative preparation and evaluation and optimization will definitely improve the outcome of any patient presenting for thoracic surgery.
You can unshare your screen. Thank you, Indrani, for an excellent talk. Dr. Indrani Hemant Kumar is not only heading the Department of Anesthesia at St. J.S. Medical College, KEM Hospital, but she is one of my best friend too. And I was sure that she's going to do the justice for this topic. And as she said that proper history, examination, investigation, definitely going to improve the lung function with the help of controlling the infection, counseling, bronchodilation, use of mucolytic agents and physiotherapy. So all the question answers are going to be answered in the end of the session. So now I request Dr. Radhakrishnan to invite the second speaker, and he will say about the second talk. Dr. Radhakrishnan. Sir, should I introduce or you are going to introduce? Sanish, should I introduce this?
Ma'am, you can go ahead introducing second
Okay,
speaker.
fine. So now the second talk is going to be on lung isolation techniques. After doing the preparation of the patient and patient is ready for the surgery, main problem is lung isolation and one lung ventilation. Doctor, just a minute. Dr. Neha Desai is our second speaker, and she is DA DND Fellowship of Onco Anesthesia, working at Calcutta as a junior consultant, Tata Memorial Center. And her area of interest is onco anesthesia, thoracic anesthesia. So as all of us knows that there are different techniques of lung isolation, especially with the help of endobronchial intubation, bronchial blockers, single lumen technique, double lumen techniques, and many more. So I request Dr. Neha Desai to share your screen, and I hand over the mic to her. Dr. Neha.
Thank you, Dr. Manjula. I would like to thank Dr. Jayshree ma'am and the rest of the ICA members for giving me this opportunity to speak here. I will, after the covering of the preoperative evaluation and optimization, I will quickly go through the lung isolation techniques and management of one lung and ventilation for thoracic surgery. So thoracic surgery, as we know, has evolved from being primarily from infectious causes to now the most common indications are malignancies and surgeries for the same. So for practical considerations, indications for one lung ventilation can be categorized as that for surgical exposure, whether it's an open thoracotomy or for VATS, prevention of contamination of contralateral lung if the surgery is for any infectious disease, and for differential lung ventilation. I'll first cover the lung isolation techniques, followed by management of one lung anesthesia. So lung isolation can be achieved through double lumen tubes, bronchial blockers, through univent tube, and nowadays rarely through endobronchial intubation with a single lumen tube. Now coming to, I will not go into details about the specific medical conditions which are the indications for lung isolation, but specific indications for double lumen tubes are when you want to prevent contamination of the healthy lung because of presence of any abscess, cyst, or any hemorrhage, or if a patient is posted for bronchopulmonary lavage, and to maintain control and continuity of airway gas exchange in presence of any fistula disruption or during pneumonectomy. Bronchial blockers, the specific indications are when there is a patient with difficult airway. So after securing the airway with a single lumen tube, bronchial blockers can be used for lung isolation. Patients requiring nasotracheal intubation or those with awake intubation. Patients who are already intubated and coming for surgery, those with tracheostomy in situ, those who have undergone previous lung surgeries and need selective lobar blockade during the surgery, and where we are expecting post-operative mechanical ventilation, the patient may have a single lumen intubation with a bronchial blocker, and then the same tube may be used post-operatively. And either can be used when the lung collapse is required only for surgical exposure. The specific indications for a right DLT can be when there's distorted anatomy of the entrance of the left mainstem bronchus, whether it is external or intraluminal tumor compression, or during descending thoracic aortic aneurysm. And if the site of surgery involves the left mainstem bronchus during a transplantation or a tracheobronchial disruption, left-sided pneumonectomies, or left-sided sleeve resections. A left DLT have been used for left pneumonectomies, where the only caution is to withdraw the tube at the time of when the bronchus is being clamped. Each has their own advantage and disadvantages, like the ease of placement, the time to for the lung to deflate during the surgery. Then DLT gives the advantage of giving CPAP to the non-dependent lung during the surgery. And it is the disadvantage of DLT is there's difficulty in selecting proper size. It is more likely to cause injury to the tracheobronchial tree during insertion. And the tracheal curve has been known to be damaged during insertion by if the mouth opening is small. Bronchial blockers, it is easy recognition of anatomy if the tip of SLT is seen. The size selection is easier. It is best in patients with difficult airway and children because of more less options of DLT in smaller sizes. They are less injurious to the airway during insertion. The disadvantages are they need more time for positioning. Repositioning is frequent, and fiberoptic bronchoscope is essential for placement of any bronchial blocker. The channel for suctioning is small. It also leads to slower deflation of the non-dependent lung for surgery. So coming to double lumen tube, the first tubes which was used were by Carlins and Burke. The present design which we use is a Robertshaw tube, which is any double lumen tube is basically two tubes which are bonded together to facilitate ventilation of a specified lung. They can be right or left-sided. The present tubes are all made of PVC with low pressure and high volume color-coded cups. And these are the various sizes which are available. The left-sided tube, which is a concavity towards the left, and the right with the concavity to the right. The right has an extra Murphy's eyes and with a different donut-shaped cuff to allow for ventilation of the right upper lobe. These are different types of the DLT which are available. This is to show a cross-section of the lumens. The Robertshaw tube is what we presently use most commonly. Size selection, the commonly used criteria are based on the patient's height, which gives easy size selection depending on the age and gender of the height and gender of the patient. And from most commonly we use 35 or 37 for female patients and 39 and 41 for male patients. Depth of insertion is from the corner of mouth. Usually the formula uses 29 centimeters for a patient who is 170 centimeter tall, and then 1 centimeter increase or decrease depending on the 10 centimeter increase or decrease in height. This is an overview of the tracheobronchial tree and where we insert the tubes. During a fiber optic bronchoscopy, this is the carina which is seen, and the longitudinal elastic bundles which run posteriorly, which helps in orientation to the left and right bronchi. Similarly, here you can see the longitudinal elastic bundles which run towards the left lower lobe and again help in recognition of the left upper and lower lobe bronchi. So technique of insertion, it can be either with direct laryngoscopy or video endoscope guided. During insertion, it is with a stillet, and with direct laryngoscopy, the bronchial lumen is first inserted with the concavity facing upwards. After the bronchial cuff crosses the glottic opening, we turn the tube 90 degrees towards the side which is to be intubated, the endobronchial intubation, and we insert until the point of moderate resistance is felt, or usually around 29 centimeters of depth, after which both the cuffs are inflated. If it is done with fiber optic bronchoscope guided, once the bronchial lumen crosses the glottis and the tracheal cuff is also crossed, a pediatric fiber optic scope is passed through the bronchial lumen, and after visualizing the carina and localization of the respective bronchi, it is advanced into the bronchus, which is to be intubated, and the tube is intubated over the bronchoscope. Then comes the important part of confirmation of auscultation of a double lumen tube. Once the tube is inserted, both the cuffs are inflated and bilateral respiration is confirmed. And after confirmation of bilateral equal respiration, that if the left lung is to be ventilated, the tracheal lumen is of the double lumen tube is clamped distal to the opening, and this opening is then opened to the atmosphere. At this point, ventilation should produce air entry only on the left side and no air entry on the right side. Once this is confirmed, the tracheal clamp is opened again, confirmation with confirmation of air entry on both the sides. Then fiber optic confirmation of position of the double lumen tube is done. First, we pass the fiber optic scope through the tracheal lumen. At this point, we should see the carina and the correct position of the double lumen tube, where we can see just the top of the bronchial cuff at the carina. And for a left-sided DLT, if the scope is passed into the right main bronchus, we can see the at this point, we can see the trifurcation of the right upper lobe. After confirming through a position, the correct side placement, we pass the bronchoscope through the bronchial lumen to confirm that it is in the left main bronchus and correctly positioned, where we can see the division into the right upper and lower lobes. Similarly, for a right DLT, for confirmation, after the confirmation through the tracheal lumen over the carina, where we can see the top of the cuff just at the carina, and in the bronchial lumen through the Murphy's eye, we should be able to see the trifurcation of the right upper lobe. Now, there are various malpositions of the DLT which can occur. The tube may go into the wrong side. It may go too far down. And if we are talking about a left DLT, it can go down too far down on the same side, or it may be too far outside. So these positions have to be confirmed by auscultation and by fiber optic bronchoscopy. Here we can see a left DLT, which has gone in the right side, in the correct side, but still it is too far in. So this will lead to problems in ventilation of the left upper lobe. And here we can see that it is again in the left side, but the cuff is still protruding outside. So this tube needs to move inside. Now, use of fiber optic for assessing the position of the DLT. Usually the pediatric sizes, which are 3.6 to 4.2 mm, which are commonly used for assessing with a DLT because of easy passage. Coming to bronchial blockers, the different types of bronchial blockers which are available is the ANT blocker with elliptical and spherical cuffs, the Cohen flex tip blocker, and the Fuji uni blocker. And recently the easy blocker, which has been made available, which has two cuffs and has a bifurcation at the end to allowing for easy placement of the blocker. These are the features of the various bronchial blockers. The ANT blocker is the only one which comes in various sizes and therefore is useful for use in pediatric patients. The 5 French can go up to in a tube up to of as small as 4.5 mm. So placement of an ANT blocker. Each blocker requires a fiber optic bronchoscope for placement. Each has a different technique for placement. The ANT blocker has a loop at the end, which is hooked onto the end of the fiber optic bronchoscope. And with through once the single lumen tube is passed, We pass the bronchoscope and we take it into the bronchus, which has to be isolated. Once the bronchus is identified, the hook, this loop is loosened from the distal end, and the blocker is advanced into the bronchus to be isolated. This is the assembly at the proximal end. There's a port for the fiberoptic bronchoscope. This is a port for passing the blocker, and this is for connecting the ventilator. All blockers come with a three-sided assembly port. This is the Cohen flex tip blocker. Here the difference is that the blocker is passed before the fiberoptic bronchoscope, and here at the distal end there is a knob which allows for rotating the tip either to the left or the right, allowing to pass it into the respective bronchus. This is a left-sided blockade where we can see the Cohen blocker is ahead of the bronchus, fiberoptic bronchoscope. And once it is turned towards the left bronchus, the cuff is inflated and isolation is confirmed. For a right-sided bronchus isolation, we must always take care to make sure that the right upper lobe is not excluded when the cuff is inflated. So here you can see that the blocker has been withdrawn and correct placement has been confirmed. This is the assembly of the ARNT blocker and the Cohen blocker. The Fuji uni blocker is similar to the Cohen blocker. It is passed before the fiberoptic bronchoscope. The only difference is here it has a preformed flexed, preformed bent tip. So the whole blocker may be turned either to the left or the right for placement either into the left or the right bronchus. The easy blocker, it has, as we can see, two color-coded cuffs. So once the the blocker is passed into the bronchus, one cuff goes into each bronchus, and it can be identified by the color of the cuff because the pilot balloons are accordingly color-coded. Then there's the Univent tube, which is a single lumen tube with a high-pressure, low-volume bronchial balloon. And it is, again, with fiber optic guided, the bronchial lumen can be advanced into either bronchus as required. Coming to briefly about lung separation in a difficult airway. If lung separation is required in a patient with difficult airway, if it is unrecognized, then after mask ventilation and if there's failed laryngoscopy and tracheal intubation, then intubation can be achieved with a single lumen tube, either with a fiber optic bronchoscope or a video laryngoscopy. Then depending on if the indication for isolation is absolute, then we can proceed with a bronchial blocker or with a tube exchanger under laryngoscopy and change to a double lumen tube. If it is a known recognized difficult intubation, then awake intubation with fiber optic bronchoscopy, and we can use either a single lumen tube or with the tube exchanger change to a double lumen tube. Here we can see that using a pediatric tube exchanger, after intubation with a single lumen tube, the tube exchanger is passed through the bronchial lumen of the DLT to achieve passage of the DLT. Then coming to lung separation in patients with a pre-existing tracheostomy. We can use a regular double lumen tube, but it becomes very long and cumbersome to use. So some shortened tubes are available. Or the easier thing to do is to pass a bronchial blocker with the 3-port connector through the tracheostomy and with fiber optic guided isolation of the lung. This is a special type of short DLT which is available, which has been made for use in patients with tracheostomy. So this is about one lung isolation. Now coming to the physiology and management of one lung ventilation. So as we know, the 4 zones of, as described by West, where it has been shown that the dependent part of the lung has the more blood. The blood supply is more in the dependent part of the lung due to gravity, and also the dependent part is which is maximally ventilated due to greater elasticity of the lung. So what happens when we put the patient in a lateral position? When the patient is in a lateral position, the non-dependent lung which moves. We can see this is the compliance curve of the lungs when they're in the lateral position, the awake and the anesthetized. And when the patient is anesthetized, both the non-dependent and the dependent lungs, they move down the compliance curve. So these patients have more tidal ventilation in the non-dependent lung, where perfusion is the least, and less tidal ventilation in the dependent lung. When the patient is on controlled ventilation favors the upper lung because it is more compliant than the lower lung. and paralysis of the dependent hemidiaphragm, accumulation of the abdominal contents on the dependent side. Also, these use of supports to maintain the lateral position all add to further decrease in the FRC and compliance of the dependent lung. Once the chest is open, the non-dependent lung will obviously get even better ventilation. The paralysis also reinforces or maintains a larger part of tidal ventilation going to the non-dependent lung because of the pressure of the abdominal contents against the upper part of the diaphragm. And the non-dependent lung FRC increases to almost 1.5 times of the dependent lung, which leads to VQ mismatch. So what leads to improvement in the ventilation perfusion in these patients? Here we can see the change in compliance of the lungs with both non-dependent and the supine positions, and in the dependent with open and closed chest positions. So during one lung ventilation, the non-ventilated lung has some blood flow and therefore has an obligatory shunt, which is not present during two lung ventilation, and which is the reason for the change in increased PaO2. So what happens during one lung ventilation is redistribution of lung perfusion between the ventilated and the blocked lung. The blood flow to the non-dependent, non-ventilated lung becomes a shunt, which results in the transpulmonary right-left shunt and gross VQ mismatch, which can become as much as 27.5%. These are the various factors which affect the blood subflow during the one lung ventilation. The airway pressure, the cardiac output can cause both increase and decrease. Surgery and cardiac output have variable effects, and pulmonary vascular resistance and hypoxic pulmonary vasoconstriction, cause change in the lung blood flows. The blood flow to the non-dependent lung is reduced by gravity, surgical decompression, and by disease, and actively by the hypoxic pulmonary vasoconstriction, which I'll cover shortly. And the dependent lung receives greater blood flow again due to gravity, diverted blood from the non-dependent, non-ventilated lung, and hypoxic zone in the dependent lung. So what is hypoxic pulmonary vasoconstriction? It is a physiological response of the lung to alveolar hypoxia, which redistributes pulmonary blood flow from areas of low oxygen partial pressure to areas of high oxygen availability. So it is active in the physiological range of PaO2 of 40 to 100 in adults, and it is proportional to the severity of hypoxia. It has a rapid onset over the first 30 minutes and then increases slowly at approximately 2 hours. It is the primary stimulus for HPV is the fall in PaO2, which causes precapillary vasoconstriction, diverting the blood away to the ventilated parts of the lung. So this is the protective mechanism which prevents the gross VQ mismatch, which we would otherwise see when the thorax is open. In doses less than 1 mAh, modern volatile anesthetics are weak inhibitors of HPV. And volatile anesthetics, they act associated with lower incidence. So there was propensity to, whether it should, thought was to use TIVA during thoracic anesthesia to reduce the effect of volatile anesthetics on HPV. But it was seen that with lower MAC, the inhibition of HPV was not that significant, and they were, so in fact, volatile anesthetics were associated with lower incidence of PPC. Now coming to management of one lung ventilation. Before initiating one lung ventilation, it is important to denitrogenate the non-dependent lung before collapse to achieve faster collapse of the lung. And for the dependent lung, after starting of the one lung ventilation, a recruitment maneuver should be done to decrease atelectasis. Ventilatory strategy, maintain two lung ventilation as long as possible. Keep FiO2 high to maintain the PaO2 because it produces vasodilatation and accepts the diverted blood flow from the non-dependent lung due to HPV. Tidal volume is usually maintained at 4 to 6 ml per kg of ideal or predicted body weight, because low tidal volume may cause atelectasis, but high tidal volume can lead to barotrauma and volutrauma in these patients. The target peak airway pressure is maintained at less than 35 centimeters of water and plateau pressure of less than 25 centimeters of water. The respiratory rate is usually adjusted to maintain a PaCO2 of 40 millimeters of mercury. Hyperventilation will increase the pulmonary vascular resistance in the dependent lung and increase blood flow to the non-dependent lung. And hypocapnia itself may directly inhibit HPV in the non-dependent lung. Low PEEP of about 0.0 to 5 centimeters is kept to restore the FRC and improve PaCO2 in the dependent lung. This is avoided in patients with COPD because it may increase the pulmonary vascular resistance and also increase auto-PEEP in these patients. The non-dependent lung, if there is a fall in saturation, we can give CPAP to the non-dependent lung with about 5 to 10 centimeter of water is usually what is given. This will not produce hemodynamic instability, and as well as usually it does not interfere with surgery except in VATS. We can also give differential PEEP and CPAP to the dependent and non-dependent lungs. Now coming to hypoxia during one lung ventilation. The incidence of hypoxia during one lung ventilation in recent times has reduced due to better techniques. The main reason for hypoxia is the ventilation perfusion mismatch which occurs in the non-ventilated lung when it continues to get blood flow, and hypoventilation of the dependent lung. Then the technical causes like blockage of the DLT lumen of the dependent lung by secretions, malposition of the tube or the blocker, whichever is used. Any condition which causes decrease in the PVO2, which can be either reduction in cardiac output or increased oxygen consumption. Conditions which will increase oxygen consumption are increased sympathetic activity, hypothermia, and shivering. Transfusion of blood causing pulmonary dysfunction, mechanical failure of any auto delivery system. Currently, the incidence of hypoxemia is almost less than 10% because of improved lung isolation techniques, routine fiberoptic, which is fiberoptic bronchoscopy, which is done to prevent lobar obstruction and to check for positions of the technique used. Improve anesthetic techniques causing less inhibition of hypoxic pulmonary vasoconstriction, and of course, better understanding of the pathophysiology of one lung ventilation. Hypoxemia, usually during one lung ventilation, a saturation greater than or equal to 90% is commonly accepted. And for brief periods of saturation in the high 80s may be acceptable in patients without significant comorbidity. However, the lowest acceptable saturation will be higher in patients with organs at risk of hypoxia due to limited regional blood flow and in patients with limited oxygen transport. And it has been shown that during one lung ventilation, patients with COPD will desaturate more quickly during isovolumic hemodilution than normal patients. And the pathophysiology of one lung ventilation involves the body's ability to redistribute pulmonary blood flow to the ventilated lung. So some of these factors are under the control of the anesthesiologist to a variable degree. So our goal is to maximize pulmonary vascular resistance in the non-ventilated lung while minimizing it in the ventilated lung. Now, how do we predict desaturation during one lung ventilation? The common predictors are high percentage of weak ventilation perfusion to the operative lung on preoperative ventilation perfusion scan, a poor PO2 during two lung ventilation in lateral position intraoperatively just before initiation of one lung ventilation, a right-sided thoracotomy because the right lung is bigger than the left lung, so you lose out on more functional lung volume during the surgery, patients with restrictive lung disease, and patients who are in supine position during one lung ventilation. And the most important predictor of PO2 during one lung ventilation is the PO2 during two lung ventilation. And the most useful prophylactic measures which we can use are giving CPAP to the non-ventilated lung and PEEP to the dependent lung, or sometimes both. So how do we treat hypoxemia during one lung ventilation? If there is severe and precipitous desaturation, then immediately communicate to the surgeon and resume two lung ventilation while you look for the cause of the desaturation. If there is gradual desaturation, which is more common, then you gradually increase the FiO2 till 1 and to achieve the desired saturation. And while this is being done, you check the position of the double lumen tube or the bronchial blocker with a fiberoptic bronchoscopy, because displacement because of surgical manipulation is quite common. Ensure cardiac output is optimal, because this is another common cause of fall in saturation because of fall in blood pressure. Decrease volatile anesthetics to less than 1 Mach. For the dependent lung, what we can do is apply a recruitment maneuver, that is an inspiratory pressure of about 20 centimeter of water for 15 to 20 seconds, and followed by PEEP. If it is not given, if it is given, then immediately after recruitment maneuver, we can increase the PEEP, go up to 7 to 8 centimeters of water to prevent further atelectasis. Apneic oxygen insufflation can be done of the non-ventilated lung with a small suction catheter and oxygen given at about 2 liters per minute. This will not cause inflation of the lung and will usually not interrupt with the surgical field. After giving apneic insufflation of oxygen, if there's still no change, we can give CPAP of about 1 to 2 centimeters to the non-ventilated lung. Separate CPAP machines are available to use during one lung anesthesia. And before giving the CPAP, give a small recruitment maneuver to include the to prevent further atrial atelectasis. We can use intermittent reinflation of the non-ventilated lung with small volumes if the surgery permits to be done, if the surgery permits do it at that time. We can use partial ventilation techniques of the non-ventilated lung like oxygen insufflation, high frequency ventilation, or lobar insufflation, wherein a fiberoptic bronchoscope can be passed through to a non-operated lobe of the operated lung and achieve insufflation of just one lobe. Pharmacological manipulations, this is basically mainly remove any drug or gas which can cause vasodilatation and improve the HPV. If all of this fails, then mechanical restriction of the blood flow to the non-ventilated lung to prevent any further shunt which is happening. And in a patient undergoing pneumonectomy, we can ask the surgeon to clamp the pulmonary artery to the operated lung early. Then apneic insufflation, if ventilation is stopped during administration of 100% oxygen and airway is left connected to a fresh gas supply, then we'll see that oxygen will be drawn into the lung by mass movement to replace the diffuse O2. There's usually no difficulty in maintaining an adequate PO2 at least for 20 minutes. It can be used safely for up to 10 minutes, and of course, arterial oxygen saturation monitoring is mandatory. Thank you and stay safe.
Thank you, Dr. Neha, for the excellent lecture.
You can unshare.
Yes.
So, thank you, Manjula.
Okay, thank you, Neha, for an excellent talk on lung isolation techniques and one lung ventilation physiology. Now, I request our third speaker of the day, Dr. Uma Hariharan. She is young and dynamic anesthesiologist. She is receiver of ICA Fellowship Award also in Mumbai. At present, she is working as an associate professor at Ram Manohar Lohia Hospital. Her special interest in biomedical research, onco-anesthesia, advanced trauma life support, and USG guided regional anesthesia. She is going to speak on anesthesia considerations in various open lung surgeries. Mainly, we do open lung surgery as a lung resection, lobectomy, pneumonectomy, and decortication. And I'm sure that she's going to tell us about the good anesthesia management of these kind of the surgeries. So mic is over to Dr. Uma, and you can share your screen. Dr. Uma. Dr. Uma. Dr. Uma, are you online?
Some problem. Dr. Sanesh.
What is it?
Hello, sir.
Will you find out what is happening, Dr. Uma? Uma's slide is shown. I think she is speaking.
Dr. Uma,
Slides,
your mic needs
her
to be
slides
unmuted.
are visible.
Yeah.
Her slides are visible, but she's not audible and visible yet.
Am I audible now? Am I audible?
Yeah, now you are audible.
Fine.
Uma, please go ahead.
Sorry. Good evening, ladies and gentlemen. I am extremely indebted to Indian College of Anesthesiology, Dr. Jayashree Sood ma'am. She is my mentor always, my thesis guide, Manjula ma'am, Radhakrishnan sir, all the respected seniors and the listeners out here. Hope we all stay safe in this pandemic. And let me start my presentation by introducing the topic, anesthesia considerations for various open lung surgery. So I will be dealing with open lung surgical procedures. So what are the various types of lung dissections for which open lung procedures are undertaken? These are basically the most difficult out of them, that is the pneumonectomies, which have a lot of post-operative complications, followed by lobectomies, segmentectomy, even metastatectomy, pleural surgeries, and airway surgeries. Out of these, the pneumonectomy is basically fraught with a lot of post-operative complications, as we will be looking into a little later. So I would just like to revise the indications for lung isolation or one lung ventilation. Even though it has been covered by the previous speakers, I would just like to revise it, because this is very important in dealing with such cases. For example, pneumonectomies, for example, with lobectomies, and especially in cases of lung abscess, empyema, and bronchopleural fistula. So as told to you previously, the lobectomies, the pneumonectomies, the lung abscess, and the bronchopleural fistulas, they constitute the absolute indications. The relative indications include sometimes upper lobectomies, for which you can do with a single lumen tube or a bronchial blocker itself, and relative indications like esophageal surgeries, especially robotic surgeries, which are nowadays done with flexometallic tubes, and sometimes even short thoracoscopic procedures. So even though the pulmonary function tests have been dealt with previously, but I would like to highlight it here that in cases of pneumonectomies and lobectomies, especially pneumonectomies, we need to be extremely cautious and careful in interpreting the preoperative pulmonary function test, especially the three-legged stool, which is very, very helpful, and the ACCP and the British Thoracic Surgery guidelines are important to follow, wherein we measure the FEV1 and the DLCO to predict the post-operative complications. Reduced post-operative DLCO, it correlates with a very, very high risk of complications and mortality following lung resection, and other methodologies may need to be applied to make the patient better. VQ scan method can be done for pneumonectomies, and the predicted post-operative values can be calculated from the pre-operative values by this simple equation. Now, let us take the example of a patient wherein the lung segment are important to analyze, especially the cases of lobectomies or bilobectomies, wherein bilateral surgeries are done or more than 2 lobes are being resected. In those situations, we need to be very careful, wherein, for example, in our patient, if the preoperative FEV1 is 63%, we need to understand that the post-operative FEV1 will be much less. That is 33.2% with this equation. So the right lung has 3 segments: the right upper lobe, the middle lobe, and the lower lobe. And the left lung has 2, that is 2 lobes, that is the left upper lobe and the left lower lobe. So a total of 5 plus 2 plus 3, that is 10 on the right side, and 4 plus 5, that is 9 segments on the left side are there. Now, coming to the preoperative cardiac evaluation, even though the risk indices are several, but this is one index which I found to be extremely useful for lobectomies and pneumonectomies. That is the thoracic RCRI, or the thoracic revised cardiac risk index, which is recalibrated by Brunelli et al. For post-operative cardiac risk prediction in lung resection, which considers 4 factors, which is previous IHD, history of stroke or TIA, serum creatinine levels more than 2, and the pneumonectomy. Now, this is very important because pneumonectomy itself confers a very, very high risk of post-operative cardiorespiratory complications. So, coming to the cardiopulmonary exercise testing, again, we need to classify these patients into low risk, moderate risk, and high risk. And this is very important to understand, because if the patient is in a very high risk category, then we may need to defer lobectomies, especially pneumonectomy. So these patients will definitely will have a lot of complications in the post-operative period, and hence we need to defer such high risk procedures. Again, VO2 max, that is a maximum oxygen consumption, we need to analyze. This has already been dealt with, and hence I'm skipping the slide. There are several predictors of poor outcome after pulmonary resection, which we need to explain to the patient, especially with the use of VO2 max, the predicted post-operative FEV1, the DLCO, and other parameters. Now coming to lung resection per se, preoperative evaluation and questions are very, very important, which we need to ask to both the patient, to the surgeon, and to ourselves. What is exactly the extent of resection? This is important because most of these procedures are done for cancers, and sometimes the extent of cancer spread is not very, very clear in the preoperative period. So sometimes these surgeries may need to be extended, not only in the extent of resection, but also the extent of duration. And sometimes these patients may have unexpected perioperative events. Now we need to understand that what is the segment or lobe which needs to be resected, or whether it is a complete lung lobectomy or complete lung pneumonectomy. Whether it is an open approach or a thoracoscopic approach. Sometimes in thoracoscopic procedures, we take the consent of open surgeries, and hence we need to be prepared so that sometimes the thoracoscopic procedure, which is done as a diagnostic procedure, may be converted to an open posterolateral thoracotomy. Then there is a very high risk of mortality, especially with pneumonectomies, which I have already told you. But there are several other problems like arrhythmias, deep vein thrombosis, and even airway related and respiratory problems. Respiratory failure is very, very common in these patients. Now, induction is generally done in the standard way. The preoperative preparation is extremely important because these patients may be smokers, they may have other respiratory comorbidities in the form of COPD or bronchial asthma, or sometimes even coexistent respiratory infections which need to be treated with antibiotics, preoperative spirometry, lung spirometry, and sometimes we need to also give bronchodilators to these patients to optimize the chest condition. Smoking cessation is absolutely mandatory to ensure a good outcome. We need to use the appropriate size DLTs. About the DLTs, this has already been dealt with in the previous lectures. We need to understand that we need to check all the DLTs, the different sizes. We need to keep the airway equipment, including video laryngoscope, fiberoptic bronchoscope, and normal laryngoscopes also need to be kept a working suction, and check the DLT tubes before actually proceeding towards the procedure. Because many times it so happens that the cuff of the double lumen tube may be faulty, and hence you may not be able to achieve a lung isolation. Generally, the mode of anesthesia is standard general anesthesia with controlled ventilation, following insertion of the double lumen tube in the supine position, confirmation of proper tube position with a fiberoptic bronchoscope, then careful positioning of the patient in the posterolateral position, and most importantly, again confirming the position of the double lumen tube using the fiberoptic bronchoscope. This particular maneuver is extremely important to understand and do it so that we don't have any glitches during the actual surgical procedure. We also need to check lung isolation and air entries using clinical methods as well as using fiber optic methods. Then it is actually a good idea to initiate one lung ventilation and see how the patient tolerates before actual surgeon exploring the affected lung. Now, this will tell you what is the extent of lung reserves these patients have, and what exactly you need to prepare. Most of these patients will require CPAP and PEEP, as well as sometimes even abandoning one lung ventilation intraoperatively, depending upon patient profile and preoperative condition. Now, intraoperative and goals and events are, as I told you previously, most importantly, verification of the double lumen tube position bronchoscopically, both before and after positioning, and maneuvers to improve oxygenation during one lung anesthesia, which has already been discussed previously. Now, generally, the blood loss for small procedures like segmental resections and all is very less, and hence may be safe. But for prolonged procedures, for pneumonectomies, and especially for decortications are conditions where we need to be very, very cautious regarding the blood loss. So proper adequate blood products must be made available, and the patient needs to be adequately prepared for this. Some institutions employ cell saver methods and sometimes even autologous transfusions. The duration of the procedure can be anywhere between 1 to 5 hours, and we must understand that this duration can be prolonged depending upon the extent of surgical resistance. Again, most importantly, we must give the patient a good pain relief, which I will be talking about in the end of my lecture. Pain relief is most important in thoracic procedures because it is a very, very painful procedure. Epidural or truncal blocks are equally good. The emergence is generally standard. Sometimes if we require post-operative ventilation in these patients, we may need to change the double lumen tube to single lumen tube before putting the patient on post-operative ventilation. Now, again, very, very important point here is not to disrupt the suture lines while changing the tube. It is better to use a tube exchanger or an airway exchange catheter while exchanging the double lumen tube for a single lumen tube. And the emergence needs to be very, very smooth to avoid any cupping or any other patient-related problems. So pneumonectomy, as I previously told you, is surgical removal of the entire lung, which is actually done as a last resort option. This is a very high-risk procedure, especially right-sided pneumonectomies, because they are associated with greater mortality than left due to diversion of the cardiac output and increase in pulmonary artery pressures and pulmonary vascular resistance, resulting in right ventricular failure and respiratory failure. There is an extremely high incidence of bronchopleural fistulas with right pneumonectomies. The quality of life is poorer as compared to lobectomies in pneumonectomy patients. Post-operative mortality is linked to increased age and other comorbidities which these patients may have. And most common indication is extensive bronchial carcinoma, especially tumors originating from the main stem bronchus, proximal to the bronchus intermedius or hilar involvement. Now, non-malignant indications for pneumonectomies are extensive trauma, traumatic lung injury with uncontrolled hemorrhage, wherein double lumen tube insertion is mandatory to prevent soiling of the opposite lung. And sometimes even chronic infective lung disorders like tuberculosis and destructive lung fungal infections. The main three specific concerns in pneumonectomies are intraoperative fluid management, which needs to be cautious and frugal. Then intraoperative low tidal volumes need to be used, and prevention of acute lung injury postoperatively. Again, expansion of the lung needs to be very, very cautious because this can also result in increased incidences of postoperative ARDS and pulmonary edemas. There are basically several types of pneumonectomy. Standard pneumonectomy is removal of the affected lung only with a safe bronchial margin. Another is intrapericardial pneumonectomy, which is a little more extensive. Either right or left main pulmonary artery is involved and the tumor is close to the pulmonary vein. Then we also have an extrapleural pneumonectomy, which is basically a radical type of resection for mesotheliomas, and completion pneumonectomies, wherein the excision of the residual lung tissue is done after previous resection surgery in cases of recurrence. And carinal pneumonectomies are actually very, very radical. They involve excision of the lung and carina in cases of distal tracheal or carinal tumors. So again, there are several scores which are more specific to pneumonectomies. Of course, the Thoraco score, which involves 9 factors, are most commonly utilized. And we also need to be looking for perioperative myocardial events and myocardial ischemias and arrhythmias, which are very, very common, both in the intraoperative and postoperative period. Postoperative dyspnea is very, very common in these patients. Respiratory assessment is mandatory, and functional assessment of cardiorespiratory interaction is also important. Again, as I told you, these patients are usually done in the lateral position, fifth intercostal space, posterolateral thoracotomies, with excision of the fifth rib sometimes may be required for adequate surgical exposures. And there is you should always look in for a possibility of sleeve lobectomy in these patients to avoid a full-fledged pneumonectomy. Now, lung retraction to expose the anterior hilum is a very, very painful thing, which can cause prolonged postoperative pain in these patients, especially the shoulder pain, for which I'll be dealing later on. and ensure that no part of the double lumen tube or suction catheter is included in the staple line. This is very, very important. We may need to withdraw the double lumen tube slightly for this. Please check the bronchial stump patency by a leak test before proper closure and insertion of chest tube before chest closure. Confirmation of availability of ICU and blood needs to be done preoperatively, and all standard ASA grade monitors are mandatory, including invasive arterial line, central venous catheter, temperature probe, urinary catheter, neuromuscular monitors, and sometimes even BIS. Vasopressors may be required to maintain arterial pressures without infusing excessive IV fluids. This is very, very important in pneumonectomies because this can result in pulmonary edemas if we are infusing a lot of fluids. Antibiotics, cautious positioning and padding of pressure points are to be done without fail. DLT insertion and checking of the position by fiberoptic bronchoscopy as well as clinically is important. TIVA is particularly suited for maintenance of anesthesia in these patients, especially during bronchoscopic evaluations, which may be required intraoperatively, and DVT prophylaxis is a must. Again, lung isolation, as I told you, left pneumonectomy requires right-sided DLTs, and hence extreme caution in insertion of right-sided DLTs to ensure correct alignment and frequent checking of the position of the right DLTs. Otherwise, it can result in blockage of the right upper lobe, and this can cause intraoperative hypoxemia and sometimes even abandoning of the procedure if this is overlooked. If bronchial blocker is used, remember to withdraw it from the blockers before stapling, and you target a one lung ventilation with a tidal volume of 5 to 6 ml per kg with a peak airway pressure of less than 35 centimeters of water. Plateau airway pressure of less than 25 centimeters of water and PEEP of 5. Aim for a normal PaCO2 if possible and avoid hyperoxia. An SpO2 of 92 to 94% is good enough. We need not have a SpO2 of 100% during the one lung ventilation in pneumonectomies. And to reduce the risk of bronchial suture line blowout, we may do an early extubation as well as try to reduce pulmonary barotrauma and prevent respiratory infections post-operatively. Now coming to lobectomies, this is actually the standard surgical management for lung cancers. The same incisions are utilized. In addition, we have anterolateral as well as muscle sparing incisions to reduce the pain relief and to be minimally invasive. Arterial line and other monitors are routinely placed. Again, the standard normothermia, normotension, normocarbia and normoxia is maintained. Test maneuver after lobe and blood vessel dissection is done. The surgeon is clamping the surgical bronchus to confirm specific lobe extirpated. Post-lobectomy, test bronchial stump with 30 centimeter water positive pressure in the this thing to detect air leaks. And Panco's tumor is again a very, very rare kind of a tumor where there is carcinoma of the upper lung sulcus invading and compressing the local sulcus, and this can also cause Horner's syndrome in the preoperative period. And here we do a two-stage lobectomy, which is again an extensive procedure. We have other procedures, lung procedures like segmentectomy and wedge resections. These are all minimal procedures as compared to lobectomies and segmentectomies. Yes, these also have a risk of hypoxemia during one lung ventilation if required. And especially if the patient has undergone a previous contralateral lobectomy or a pneumonectomy, which is generally the case, because these patients are cases of metastasis or recurrence, which are operated for such procedures. We need to be extremely cautious. We need to prevent pulmonary overinflation. Again, in all these procedures, positioning during surgery, we need to be cautious about the neurovascular compression. There has been several incidences of post-operative neurological deficits in such instances, and it can be very, very difficult to treat such patients. Padding of pressure points is extremely important. Now, again, coming to the extubation of these patients, it should be guided by the parameters, the standard parameters, the predicted post-operative FEV1, and the awake, alert, and warm and comfortable patient. Of course, thoracic epidural plays a very, very important role in such circumstances in aiding extubation. Coming to lung abscess is a suppurative process in the spectrum of anaerobic pleuropulmonary disease, including aspiration pneumonia, necrotizing pneumonia, lung abscess, and empyema. There are several sizes. A lung abscess is more than 2 centimeters in. If it is more than 2 centimeters in size, it is a lung abscess. If it is less than 2 centimeters in size, it is known as pneumonic effusion. Lung abscesses are recognized since very long time, and anaerobic bacteria were detected in these empyema fluids when they were initially identified. And the role of aspiration was identified as the most important cause of these conditions. The decreases in the cases of lung abscess attributed to early and broad spectrum use of effective antimicrobials and improved management is known. These patients, they present with fever, malaise, night sweats, and weight loss. And chest X-ray shows parenchymal radiolucency, surrounding thick wall, and radiolucency with an air fluid level. Chest CTs are generally helpful in identifying the correct diagnosis. Sometimes even ultrasound can be extremely valuable, which is also used for drainage of the fluid. Pleural effusions more than 1 centimeters in febrile patients need to be aspirated, and intrapleural fibrinolytics are specially employed in such situations, especially in cancer patients. Most important thing in these patients is to rule out bronchopleural fistulas, as intermittent positive pressure ventilation results in failure to ventilate the unaffected lung and tension pneumothorax in the affected lung. Of course, soiling of the unaffected lung is also very common if it is not identified preoperatively. Mortality is very high if not treated preoperatively. Investigations on the pleural fluid are again very important. Most importantly, we must also do a thoracic ultrasound or lung ultrasound and a chest CT scan. There are also several differences of opinion regarding the size of the chest drain. Some people prefer a large drain, some people prefer a smaller one, depending upon institutional practice. Anesthetic management, two most important things which must be remembered are proper positioning of the patient and lung isolation to prevent soiling. Thoracic ultrasound before pleural procedures reduces complications, and the cornerstone of management is fluid drainage, antibiotics, and nutrition. Bronchopleural fistula should be assumed when empyema occurs after thoracic surgery. Thoracotomy is a very, very painful procedure, and hence post-operative analgesia is extremely important. Another important thing which we must remember in these procedures is hemoptysis, which can occur, and hence intraoperative hemoptysis may be very, very life-threatening and can cause complete airway obstruction, which we may not be able to prevent if we are not using a double lumen tube. Cultures need to be sent and treatment given appropriately. The anesthetic concerns are most importantly is to avoid sepsis. DLT facilitates suctioning of the debris as well as copious secretions in the tracheobronchial tree, as well as prevents the risk of soiling. Expect a massive blood loss, as I told you, during decortication. Gentle and gradual re-expansion in chronically collapsed lung is very, very important to avoid the development of pulmonary edema upon re-expansion. Extubate in the operating room only if standard criteria are met. Otherwise, sometimes these patients who are not meeting the criteria may need to be ventilated post-operatively. Now, coming to the final condition, that is bronchopleural fistula. This is the most dreaded complication of pulmonary surgery, as well as after sometimes complicated tuberculosis patients. It is also one of the most common cause of post-operative morbidity and mortality. Earlier, Carlin's catheter was used for cases of right-sided fistula, and Gordon's green tube was used for left-sided fistulas. Now, these fistulas, they are divided into three categories based upon their size, that is a small, medium, and large. Small fistulas are generally asymptomatic, or they are known as masked fistulas. Medium fistulas are where IPPV is possible with normal flow of gases, but yes, we need to prevent pneumothorax by forceful IPPV. And large fistulas where controlled ventilation is actually impossible despite maximal gas flow. So this is the most treacherous of the three bronchopleural fistulas, and we need to be very careful during surgery. Veroli et al. Also classified these bronchopleural fistulas depending upon the time of onset following surgical intervention, early, intermediate, and late. Morbidity rate is also very high if not treated. Bronchopleural fistulas following pleuropulmonary infection can occur at any point, and this is basically a sinus tract which develops between the main stem, the lobar or the segmental bronchus, and the pleural space. Etiology is most commonly post-surgical, sometimes post-radiation and chemotherapy, and especially in patients with diabetes mellitus, steroid therapy use And heavy smokers, COPD, bullous lung disease, this is extremely common, especially in patients with low nutritional status, or if the surgical resection has been extensive with lymph node dissection, and elderly patients. Preoperative assessment of respiratory function and other preoperative preparations are standard in these patients. Double lumen tube needs to be used, and chest condition needs to be optimized preoperatively for a good outcome, because these are semi-elective procedures and hence they give adequate time for optimization. Anesthesia is again important to understand that preoperative thoracic epidural with the main objective of maintaining oxygenation and ventilation, avoiding tension pneumothorax and avoiding soiling of the good lung is the most important thing in these situations. Protection of the lung with DLT or bronchial lumen is extremely important and mandatory in bronchopleural fistulas. It is pertinent to understand that some patients with small leaks without infection can be managed with single lumen ETTs, hence preventing the risk of one lung ventilation and hypoxemia. In other patients, two techniques of anesthesia, either awake double lumen tube or sometimes sedation can be utilized, especially in difficult airways. Spontaneously ventilating GA with DLT insertion can be done under deep anesthesia, especially in cases of large fistulas. And the verification of DLT position with differential ventilation or FOB can be done. But the most important thing is positioning, head up position with affected side down. Maintenance of anesthesia is done with IPPV to the healthy lungs and small tidal volume CPAP below the critical pressures to the other lung. TIVA can be utilized, and emergence has to be done very slowly and cautiously to avoid high airway pressures. Consider gentle manual hand ventilation rather than putting the patient on the ventilator, especially in large fistulas. Thoracic epidural analgesia can be extremely useful. Patients, most of these, they require post-operative ICU and HDU monitoring, and they also have very high incidences of arrhythmia. The two main hazards with bronchopulmonary fistulas are air leaks and spillovers, which need to be avoided by either occlusion or exclusion methods. The safety first method by Parkhouse, which was as early as 1957, was a very early study to estimate the size of fistula, and spillover from the fistula needs to be avoided both during surgery and during the post-operative period. Now, coming to pain relief, a short overview of the pain relief. Actually, this is a full-fledged topic in itself, but still I'm just touching upon it. The gold standard is still thoracic epidural analgesia. It is better to place the thoracic epidural preoperatively in the awake patient and give analgesia during the surgery as well as in the post-operative period with patient control epidural analgesia using local anesthetics and opioids. Intercostal nerve blocks, paravertebral blocks, or paravertebral catheter placed by the surgeon. With the advent of ultrasound, these truncal blocks have become extremely common and easy to apply and very, very effective and accurate. Now, erector spinae block has also been utilized for some of these procedures. Intrapleural cryoanalgesia, intrapleural block with open catheter insertion by the surgeon can also be utilized. IV PCAs are used in patients with coagulopathies or other anatomical abnormalities or for supplemental analgesias, and systemic analgesics as well as other modalities form part of the multidisciplinary or multimodal approach used in these patients. It's very pertinent to understand that thoracotomies are very, very painful. Literature describes it as the most severe surgical pain ever possible. Hence, relieving of pain in these patients is the prime responsibility of the anesthesiologist, and to make the patient opt for it in the preoperative visit itself. The cause for pain are multifactorial, but the most important is the retraction, which is done during these open procedures. Resection or fracture of ribs, which sometimes may be required for adequate lung exposure. Dislocation of the costovertebral joints done during the procedure, injury to the intercostal nerves, and sometimes even pleural irritation by chest tubes or the chemotherapeutic agents which are being given by the surgeon. Now, implications of an unrelieved post-thoracotomy pain are multitude. multiple, and the most important problem which can occur include respiratory failure due to splinting of the chest. The patient may not be able to generate adequate tidal volume or take adequate breaths. This will lead to inability to clear the secretions by effective cough. This can lead to pneumonias and continued post-operative ventilation and ICU care and prolonged antibiotics and other multi-organ dysfunction problems, as well as it also facilitates the development of incapacitating chronic pain, which is also known as post-thoracotomy pain syndrome. This is a very, very severe form of pain, which is very difficult to treat, and hence it is better to prevent than to treat. Another very important cause of pain is ipsilateral shoulder pain. Now, this pain is also very unique to thoracotomy patients and has multifactorial causation. It is only partially relieved by NSAIDs and acetaminophen, and hence other methods need to be applied. One more important aspect of this shoulder pain is that it is not relieved by thoracic epidural analgesia, which is routinely given to such patients, and hence we must employ other measures because this is a referred pain and not a direct pain. Referred pain via the phrenic nerve along with contribution from positioning and other problems like impingement and ligament strain, especially to the shoulder. Analgesic methods which are commonly employed and described in literature for shoulder pain is superficial cervical plexus or interscalene brachial plexus blocks, phrenic block or intraoperative infiltration of the periphrenic fat pad with lidocaine or ropivacaine. Now, epidural analgesia, coming to epidural analgesia, median or paramedian approach can be employed. Paramedian approach is, it is easier to locate the epidural, thoracic epidural space using the paramedian approach. Awake technique is generally recommended. In the United Kingdom, only awake thoracic epidural insertion is recommended and not after putting the patient to sleep, because insertion in anesthetized or paralyzed patients is associated with potential spinal cord cannulation, as the ligamentum flavum is discontinuous at the thoracic level as compared to the lumbar level. Preemptive analgesia is said to be most useful for patients undergoing thoracotomies and hence must definitely be given. Since, as I told you, since shoulder pain is a referred pain, it is not covered by TEA and hence we must employ other measures. Intercostal nerve blocks is one of the simplest blocks wherein you can either give a single local anesthetic injection or you can give injection in 5 interspaces. Continuous infusion of local anesthetics for post-operative period with indwelling catheter can be done with subpleural or extrapleural pocket, especially for thoracoscopies. Intraoperative cryoneurolysis of intercostal nerves was also done previously, but now literature says that it is associated with a very high incidence of neuropathic pain, dysesthesias, and muscle paralysis. Paravertebral block is a very, very useful and excellent block.
I think, Dr. Uma, you can conclude your session.
Yes,
we are
it's done.
The time.
Yes, ma'am, it's done. It's done, ma'am. It's done. Thank you very much for your patient listening. I am extremely grateful to Indian College of Anesthesiology and everyone for your patient listening. Thank you very much.
Thank you, Uma, for your excellent talk on anesthesia considerations. Now, I think all the speakers should join and question answer session can be conducted. As
I'll just stop sharing my screen.
Yeah, please.
Yeah. Thank you.
Sanesh, could you please put up the questions for the QA section?
If I may, there was a question on tidal volume.
Yeah, please go ahead.
During one lung ventilation, someone has asked that books mention 10 to 12 ml per kg. The recommended tidal volume now is 4 to 6 ml per kg of predicted body weight for all patients. Even for normal ventilation during anesthesia, low tidal volume is what is recommended. So for one lung, we don't use such high volumes anymore. So it's usually 4 to 6 ml per kg of predicted or ideal body weight for the patient.
There is a question on role of incentive spirometry or yoga before thoracic surgery. Incentive spirometry is an integral part of the preparation and optimization of a patient presenting for thoracic surgery. So basically, when you're doing an incentive spirometry, we are actually trying to improve the expiratory flows, right? The patient is asked to blow the first ball, the second ball, the third ball. So when the patient is, so basically we are trying to improve the expiratory flows. But remember, with this, we are not only improving the expiratory flows, we are also improving the inspiratory flows, because the patient has to take a deep breath to give that kind of an expiration. So basically, incentive spirometry is extremely useful and has to be part of the preoperative preparation. And second thing is about yoga. Yoga, the breathing exercises, you have the anulom vilom, right? So basically, when the yoga teacher is teaching you, he will give you a count of 4 during inspiration, but he'll give you a count of 8 during expiration. So that's again a breathing exercise to enhance your capacity. So yoga as well as spirometry, both are extremely useful in your preoperative optimization of a patient for thoracic surgery. I think does that answer?
Can I ask one question?
To whom?
To Dr. Shikha. I want to know what are the advantages of blocker over the double lumen endobronchial tube. Shikha, are you there?
Neha.
Neha, yeah.
Neha.
And the advantage is mainly when we are anticipating a post-op ventilation. So when we want to avoid tube exchange, or sometimes patients when they already have a tube in situ when they come for from an ICU for any open procedure. We at our center use blockers for patients who undergo transthoracic esophagectomy, because they have 3 different incisions. There's the thoracic incision, the abdominal, and then the neck incision. So sometimes we use the blocker during in these patients to avoid change of tubes in these patients. So the it's just that there is easier to insert, less traumatic to the patient. Of course, fiberoptic bronchoscope is mandatory for all these patients. And sometimes if there is bilateral wax surgery, so with blockers, we've also seen that especially with an easy blocker, it's easier to alternate one lung ventilation, where you just inflate the alternate cuffs when required. And the main advantage is just I think the trauma that is less compared to a DLT. And also useful in patients with tracheostomy and where difficult airways, whether it's anticipated or unanticipated.
And one more question I want to know from you. Is there any role of USG machine to find out the proper placement of endobronchial tube?
Yes, it has been described in use of USG to see the lung sliding as we clamp the alternate lumens of the double lumen tube. Just as we auscultate the chest, we can also see the lung sliding sign after clamping to confirm the placement of the tube, as we see for other intubations.
Okay, thank you.
And there was also a question on how to apply CPAP to the non-ventilated lung.
Yes.
So there are special CPAP machines which are available where you can connect the oxygen, and they give us fixed CPAP of about 5 centimeters of water to the non-ventilated lung. So once the once a lung has been isolated to the lumen of the tracheal lumen, if it is a left DLT and the right side is being operated upon, then we can pass a small suction catheter with oxygen about 2 to 3 liters per minute along with the CPAP machine. Another technique is where we can apply a normal bacterial filter, and oxygen can be applied to the EtCO2 port. And with intermittently, we can block the filter with our thumb. So that gives about CPAP to the non-ventilated lung. Okay. And there are special CPAP machines available which can be used for the non-dependent lung.
Okay. Now I have a question for Dr. Uma. I want to know, after opening the chest, sudden desaturation occurs, then what are the causes and how you are going to treat it?
Ma'am, when you open the chest and sudden desaturation occurs, first we need to find out whether we have positioned the tube properly or not, because that is the most important.
Position before, tube placement has been confirmed after intubation.
Okay.
Now when you are doing the surgery and when you have opened the chest and sudden desaturation occurs after opening the chest.
Yes. Ma'am, this could be because of patient already having a poor respiratory reserve, and or if the patient has developed a pneumothorax, or especially in situations of bronchopleural fistulas, where there is a very high, large volume fistula. And in such patients wherein we are giving IPPP without knowing the extent of the fistula, then it can cause sudden desaturations. Or in cases of pneumonectomies, when we open the chest, the opposite lung may also be involved and we do not know the extent of the tumor, especially the bronchial tumors or the low tumors which are there. Or sometimes there may be sudden airway obstruction because of airway hemorrhage. Now, airway hemorrhage can occur due to sudden changes in the pressures of the mediastinum and the exterior in such high-risk patients. And this can also, there could also be desaturation because of some problem in the anesthesia circuit itself, or some oxygen supply itself. So these are all problems which are solvable, but sometimes we need to understand that such incidences of sudden desaturation may be very life-threatening and may require abandoning of the procedure for the time being and looking into the causes.
Okay.
Ma'am, there was one question on use of erector spinae block for thoracic surgeries by participant. I would like to emphasize that erector spinae block was initially brought into action because of post-thoracotomy pain. It was initially brought for post-thoracotomy pain, especially chronic pain patients who are having such problems. So erector spinae block can be extremely useful, especially for VATS procedures, for patients who are having rib resections. It can also be used as a supplemental analgesia, provided if the patient is having, especially if the patient is not having sufficient pain relief for thoracic epidural block and or paravertebral block. It is an extremely useful and very simple block which can be performed ultrasound guided and resulting in very good pain relief.
I want to know one more thing, that yes, how much oxygen desaturation is permissible during one lung ventilation from the baseline?
Ma'am, during one lung ventilation, as I told you, a saturation of up to 90% is okay. But below that, we need to really pull up our socks and look into the factors, or do something else. But one thing which I would like to say is that 92 to 94% is the recommended one which is given in literature. But practically speaking, when we are in the theaters and doing thoracic anesthesia, we do give a little bit of leverage by applying CPAP or PEEP, or by switching on to 100% oxygen, and or sometimes asking the surgeon to relax the retraction, or looking into other causative agents. So we can go down up to 90% or sometimes even 88%. The more important aspect is the PaO2, which we need to look into by doing the ABGs.
No, but if patient's saturation before surgery is 90%, then how you are going to maintain the 90% saturation during the procedure? So the baseline saturation is 90%, then how much is permissible?
Ma'am, if the baseline saturation is 90%, then we need to relook our respiratory function tests.
No, but
because
the surgery
as
should
ma'am,
be done or not done? We have to postpone the surgery if 90% saturation is there.
no, ma'am, it is not a postponing of the surgery.
my
It is just the
question is
optimization of the patient and taking up the patient for surgery after understanding that yes, this patient may have intraoperative complications and severe hypoxemia, which may not be relieved with our standard maneuvers.
No,
So
my
instead of
question is
abandoning the procedure intra, we need to relook into our pulmonary function tests and DLCO and other things, whether the patient is actually suitable for a major lung resection, especially pneumonectomies. But yes, if it is a small procedure, for example, wedge resection or metastatectomy, then probably we can still consider. Ma'am, Indrani ma'am and Neha ma'am, please.
I think the 10% saturation drop from the baseline should be permitted, whatever
Yes.
it is in the beginning,
Yes.
because
Yes.
otherwise it is difficult for us to
Yes,
proceed.
absolutely right.
Yeah,
Absolutely
Indrani
right.
can comment on this.
Actually, I would ask the surgeon to change his, I will not allow a pneumonectomy at 90%.
These patients will definitely have some abnormal PFT already. So it's
Yes,
unlikely that we have a direct 90% add-on table and they would have some abnormality in the pre-op investigations itself.
See, an aged patient, say a patient around 96 years old, coming for a lung surgery, especially carcinoma surgery, patient may be having a normal, as per the predictor for the age, around 96, 97, not beyond that. You are not going to have 100% saturation in that particular patient. In that particular patient, with the comorbidities, it may come down to sometimes 91, 90 or something of that sort. When we accept the patient, what is the reading? From that particular reading, how far you can go, that is the crux of the question what Manju was asking.
Yeah.
Sir, not less than 85%, no matter what.
Yes.
Sir, no matter what.
Yeah.
Not less than 85%. I'm not going to talk about...
Now you have come to 85%. I agree to that. Yeah.
Yes, not less than 85%.
That's what we are asking, because it can come down depending on the situation every particular time. Because if patient is having only say 94% normally, patient can be allowed to go for some 4 or 6% down, because you can easily go with 88%, 87%. But see that every other particular problem is solved.
Thank you, sir.
No.
Thank you, sir.
Say, what is the biggest in a lung surgery? What is the biggest problem? What is a drastic complication? When the lung is open, when the thorax is open, what sort of things rather put you to some sort of fear? In a thoracic surgery, it is always a hypoxemia. And find out the reason for the hypoxemia and correct the hypoxemia. Because if you know how to correct the hypoxemia, probably you may be able to survive the situation. But nobody was telling about in the optimization, Indrani was supposed to regarding how the patient is going to having a physical fitness as well as a nutritional fitness, how the patient is going to be built up for the particular surgery. A patient is kept optimal, or patient is physically made fit for a particular surgery.
So that's why I said the 5-prong attack, the 5 prongs.
Yeah.
All the 5 prongs are very important. Yeah. Stop smoking, treat the infection, give bronchodilators, give steroids, treat anemia. Then you also have to give the IPPB or the incentive spirometry. All these are going to add to the optimization.
And what is the minimum FEV1 you may have?
2 liters. 2 liters for pneumonectomy. 2 liters.
2 liters for
pneumonectomy.
Okay, correct. 2 liters for pneumonectomy. But don't you think sometime back in the literature, it was being shown 800 ml as a magic volume? 800 ml as a magic volume, probably you may be able to accept the patient there.
So that is only for wedge resection. For 1 liter for lobectomy and 600 up to minimum of 600 for wedge resection.
Wedge resection, I agree. Anyway, that's still confusing, I must say. What is it is correct. 2 for pneumonectomy, I agree. Something like 1.5 for a major lobectomy. And still you can reduce for a minor lobectomy, I mean upper lobe.
Wedge resection.
Wedge resection, you may be able to do. These are all proven statistics, but still it may vary. Okay, anything else, Manjula?
But I think we have done. Now, Jayashree Madam is going to conclude, or I have to conclude?
No, Dr. Jayashree is going to conclude. Before that, well, from today onwards, we are introducing certificate presentation for the faculty as well as for all the participants. They all will be given the certificates of participation. And Dr. Sanesh, could you tell something on that?
Yes, sir. From this edition onwards, we are providing e-certificate of attendance to all the participants. The only precondition is they have to fill in the feedback form. Then only we'll get their proper email address and name. That's all. And for the panelists also, we are trying to introduce the e-certificate of appreciation.
Right. Thank you. Thank you very much for that very lively webinar. Thanks a lot, Manjula, Indrani, Neha, and Uma. And of course, Dr. Radhakrishnan, who's always there. And thank you very much. It was very interesting, and we had several questions, and they were all answered so well. And so we conclude today to continue next week, subsequent week on Wednesday, as has been already shown by Sanish on the slides, that the next week we have the same on. Sanish, when can we see that? Weaning of the patients from mechanical ventilation. Thank you very much.
UPD and weaning.
Thank you, madam, and bye.
Thanks a lot.
Bye, everybody.
Thank you very much.
Bye,
Thank
everybody.
you. Bye-bye. Thanks a lot.
Bye-bye. Good
Thank
night.
you. Yeah.
Thank you,
for
ma'am.
the
Bye. Good
opportunity,
night.
ma'am.
Good night. Good night.
Thank you, ma'am.
Okay.